This second talk is going to be on the descending dissections and what we see with infrarenal enlargement, which is a real challenge. Again, these are my potential conflicts, none relate here. And this is an example, patient who had a very large pseudoaneurysm, lose their voice. We were able to put a stent graft in and got her voice back, but you can see over time this infrarenal aorta continues to enlarge. And looking at that in some of our early data, we looked at patients with acute dissections where when we put a stent graft in the descending aorta, over time the true lumen goes up, false lumen goes down. And over time, if it doesn't go into the infrarenal aorta, these remain pretty stable. In chronic dissections, though, in another group of 72 patients where we looked at this, again, the true lumen goes up, false lumen in the thoracic aorta goes down. But when patients that had dissections that went into the infrarenal aorta, that infrarenal aorta keeps getting bigger. And so that's the real challenge that we're looking at. So from that early data, we really decided that we ought to be treating these patients in less than 14 days if we could. Other criteria greater than 40 millimeter total aortic diameter. And these data have been pretty well substantiated, although classifications have changed. In this interval between 7 and 14 days, if you can treat them and keep them in the hospital, is safe. We don't see retrogrades then, and really to do them before 30 days. Now, there are some other very interesting technologies that are coming along. I'll cover these quickly, but you've heard the names over time. This is one where with a Cook dissection stent, covered stent here, and then the remainder of the aorta with an open stent. And what that does acutely is to open up that infrarenal aorta where we later get dilatation. If you need to, you can cross it and put branches or stents into the branch. And these have been extended now to where what's called stabilized, where you balloon dilate, rupture that septum and completely increase the size. You don't want to use a compliant balloon here because you can rupture the aorta, but if you're careful, bring it out to a full size. And what's been very impressive here in the early results is that we get complete remodeling early on in these patients, which eliminates that later then potential for enlargement. Again, you can cross these and put additions in. In Europe, you're familiar with the cardiatis stent. These are some examples of how you can cross the viscerals. And with these technologies, either branched or these open stents, we're eventually going to be able to treat these, I think, and get regression then from the very beginning. So very rapid evolution continues here like all the other areas. With that, I'll happy to stop and answer questions. I know you're a little behind too, so thanks very much for the time. Appreciate it.
Impressive, Rod. It's fantastic. Here is Ivo speaking.
Yes, you've got experience with this, my friend. So you
really fantastic. In fact, in case Dr. Khanna allows me, I wanted to ask you about the distal part of the proximal ascending aorta dissection. In your cases, did you do proximal entry site sealing with the stent graft, or you continue to implant some distal devices, covered stent with chimneys or bare stents into the arch? What would be your strategy?
Well, what we've tried to do now, and we don't quite have all the technology you've got, but we put in the descending, we cover that entry tear with a covered graft, although I don't think you necessarily need to do that. And you've got some experience with it if the aorta is not too big. And I think eventually we're going to cover that whole descending aorta if it's small enough with this open wire configuration so the branches stay patent. And it's a whole new way of thinking about it, but we remodel that aorta from the beginning. And again, I think you could comment on that. You've got experience with cardiatis and being able to do that, so.
Absolutely. As you mentioned, the timing is very important. Probably in case that the intervention is done on time into the acute phase, we can be really more conservative to seal the proximal. But in case the time is going, probably we need more the so-called centralization of flow into the lumen, because in this case, there is not any more dynamic compression, but it's static compression. And in this case, to seal only the proximal entry is not enough.
No, you're right. So what's that interval? We're going now, we try to treat them before 14 days if we can, or particularly less than 30, but how long would you wait?
Absolutely. And in our series, in case we leave the distal part on his own, in most of the cases, we need additional interventions of the future. But just the opposite, in case we cover the proximal part with a stent graft sealing and do distal bare stent and some branches stenting as well. In this situation, we don't need any additional intervention in the follow-up. This is our experience.
Yeah, no, I think you're right. And that's going to help us get rid of this problem of late infrarenal dilatation, which is a big problem. Very hard to treat, and with an open case you can do that, but it's a high morbidity mortality scenario. So the evolution continues to change, and as soon as we think we figure out one part, there's more to be solved, but it's going to come very quickly now, I think.
Absolutely. And we know very well that whole the aorta is sick. In fact, in case we have only the proximal segment treated, it doesn't mean that the aorta is healed. And we know the incidence of distal surgical or endograft aneurysm and dissection formation is approximately 20%. So we have to have in our mind for that. And probably the initial stabilization of the aorta is probably the best way to treat in the future the patient.
I think you're right.
True. But I mean, Dr. Ivo, you have a good experience with MFM and dissections. What is, I mean, we use non-covered stents in form of the Cook's, dissection system, which we find to be quite good. They are a fixed size, 44 millimeter in diameter and with large struts, so you can tackle the side branches. But there have been a lot of controversy. I do use those, but a lot of controversy about their use, although in stable trial, it actually thought that it was concluded that probably it may be of benefit. But, what is your experience between the two stents, MFM versus, a Cook's dissection system stent?
It's a fantastic question. In fact, the MFM we have used in several cases off-label. The MFM, that is in fact a flow diverter. And there is our opinion since the beginning of the technology that probably the MFM is more suitable for dissections compared to aneurysm. And the follow-up of our patient, both included into the Streamliner and Dragon trial, showed exactly that in big aneurysm, the MFM is not good enough, but for dissection, in order to be used to stabilize and to centralize the flow into the true lumen, it's really a very good device. The problem is coming in case we have to do a secondary side branch intervention through the MFM. We have done several. It's possible, it's doable, but the problem is the compression of the dense mesh. In fact, it's several layers mesh that there is a trend to compress the stent implanted, I mean the side stent. But otherwise, for dissection, to centralize the flow, it's really fantastic. And we don't see any difference in terms of late results in comparison MFM, dissection Cook device, and even the Sinus XL Optimate. It's also possible to use this big stent to centralize the flow into the true lumen.
I think the difference is the radial force probably, because the Cook stent's very flimsy and it's hard to dilate and keep it out, and the others are more substantial. So
agree, absolutely.
Thank you very much, and